Hello, good evening. I know have you been? Oh, good to see you. Hi, Pippi, how are you? Thank you. I Sparkle for Sickle Cell. Thank you. Thank you for joining. Good evening. I'm just waiting for a few more people to come in. So, hello, doctor. Thank you for joining. I'm trying to wave at you, but I don't know. So can you hear me clearly? Pipi, can you hear me clearly? Because my window is open and then the cars. So can you hear me clearly? Okay. Hi, Green-eyed Kai. Thank you for joining. Dr. Adelabu, thank you for joining. We have 4 people online now. Okay. Thank you. So should we just start? I think we should just start because yes, you can. Okay. Thank you. Thank you. Today is Sunday, and I know that there are quite a few a few things today, especially for those that are in Nigeria. So fit well chilo, thank you. Okay, thank you. So that's good. We have 5 people. I guess more will join us online. So let's start. Good evening, everybody, and thank you for joining. Welcome to another episode of Sickle Cell Convos with Mrs. O. For those of you that are just joining for the first time, my name is Oyeshola. But most of my friends in the sickle cell community call me Mrs. Zo, and sickle cell covers with Mrs. Zo. I'm 38, soon to be 39 HBSS. And I'm passionate about everything sickle cell. I believe that we need to educate ourselves. We need to educate the warriors in particular because you can't have a condition and you're totally ignorant. I started my sickle cell advocacy journey in 2016, and we started this page, Sickle Cell Convos, in 2019, and yeah, the page is 2 years now. So we bring different professionals, different doctors come and speak to us about different aspects of sickle cell. We've had so many topics. If you're less busy, go to our IGTV, you'll see so many topics. We've done mental health and sickle cell, we've done preapism, we've done pregnancy and sickle cell, we've done red cell exchanges, we've done hydroxyurea. So many. To be honest, it's a minefield of information. So many of it. You can just check. You can just check our IGTV when you're less busy. Okay. So today we're discussing. Just give me a minute. Okay, good. Okay, I wasn't feeling too well, and I did a PCR test, and I just got the results. It's negative. Okay, all right. Thank goodness for that. So today we are discussing pain management and sickle cell, and why pain management and sickle cell? Because you cannot can you separate pain from sickle cell? I don't think you can. It's such a key. It's such a key part of the. It's such a key part of the condition. First, let me apologize if I look a bit drained. I'm not feeling too well myself. Yeah, I'm not feeling too well myself, and so I've only just struggled to be here because I don't want to cancel it. Hi, Tineke, welcome. I didn't want to cancel last minute. That's why I've dragged myself here. I didn't even go to church today. On Wednesday, I fell. On Wednesday. I was sitting on this chair. I wanted to get something, and I stretched and I fell. And I fell on my right knee, which is the knee that I've been getting steroid injection in. So I think it aggravated everything, and the pain is back. And also my transfusion is on Tuesday, so I've been struggling a bit with those little crises. So I apologize. I'm going to try and make it fast. That's because for so many reasons. Some people want to go and watch Big Brother Eviction, and SCAF also has a clubhouse forum at 6. So I want to be fast and we can join them. So pain is sickle cell. Yes, Sparkle for sickle cell. Thank you for saying pain is sickle cell. So today we're just going to be talking about pain management and sickle cell. So I'm going to be adding Dr. Adelabu now to join us. Personally, someone that I've seen personally when I was in Lagos. Hi, Demos. Thank you for joining. Good afternoon, doctor.
Hi, afternoon.
Oh, good to see you.
It's after a very long time.
After a very long time, yes. So I was just saying that Dr. Adelabu is somebody that is a doctor that I know personally, has treated me personally, has seen me personally. So I'm glad that he could join us. I just wanted to add quickly for those that are joining for the first time. So even though I live in the UK, I used to live in Nigeria, and most of my sickle cell journey was in Nigeria. And Dr. Adelabu is based in Nigeria. So some of the maybe medications they may be calling, or some of the terms may not be known to you, for those that are based maybe in America or in the UK or wherever, Canada. So it's just because, some medications are just in some particular areas, but sickle cell is sickle cell all over the world. So just for you to know that, we bring different people from different parts of the world. So just pick what you can from it, just in case you don't know some of the terms he's saying, maybe because it's not known to you. Okay, good evening, doctor. I'll just give you the opportunity to introduce yourself to everybody that is watching.
Yeah, thank you very much, Mrs. O. And thank you for having me on this conversation. I'm really glad to be with you today, and with all those that have joined online. So I will be listening later to at least get to have a conversation and exchange ideas, and also give out some information. So thank you very much for the short intro. I'm Dr. Adelabu. I'm a clinical hematologist and physician. Currently, I'm working at the Marigold Hospital and Critical Care Center in Lagos. And I'm also just about to resume at the College of Medicine, University of Lagos, as a lecturer in the Department of Medicine.
Oh, okay, nice. So you're going back to the four walls of Hyderabad.
Yes, I'm really looking forward to it.
Okay, thank you. So without wasting too much of our time, I have a few questions. I would think they'd be too much, but my first question is, what is pain? Can we define it? How do we define it?
Okay, so yeah, of course, there are medical definitions for quite a number. Everybody knows pain. You know what pain, really is. Of course, pain is a sensation, meaning that it's actually one of the essential effects that one can get. Of course, pain is also an obnoxious sensation, so it is not a good sensation. And the reason it's that way is that it's a pointer to something. So anytime there's pain, it means that something, somewhere in the body, something somewhere is going wrong, and that draws attention to that part of the body, and thereby to say, not like, of course, if one puts one's finger close to a candle light or candle fire, because the burning sensation from there would make one to withdraw from it. Of course, I won't want to give a medical definition of it, but for we all know everyone, including even a newborn, baby, experience pain at one point or the other. So we all do understand what that could mean.
All right, thank you. There's something that you brought up. You said pain is a pointer of something. I think I want to ask a question about this, but I'll keep it for later. Hopefully, I remember. I've written it down on my notes. Okay, Dr. Liabu, please, can you quickly just tell us, because now we're talking about sickle cell management, so this pain is specific to sickle cell. Before we go on, I know most people just talk about the bone pain crisis, the pain crisis, the vaso-occlusive. Can you just quickly tell us the types of crisis? When we're talking about sickle cell, what are the types of crises that one can have? And those types, do they all involve pain? Or there are some types of crises that you would have it but would not give you pain?
Okay, thank you very much for that. So, as you rightly said, even in your intro, that pain is one of the key and one of the hallmark of sickle cell disease itself. In fact, that's the characteristic feature of the condition itself. And so, talking about crisis, that's also where it comes from, because the commonest, most common form of crisis in sickle cell disease is actually what we know as the acute painful crisis, which generally is known as the vaso-occlusive crisis, just based on the mechanism by which the pain does develop. And we know that sickle cell, actually every manifestation of sickle cell arises from two major, let me say, processes or mechanisms. For one of it is occlusion of blood vessels from this change in the red cells. Of course, that's where the name sickle cell actually come into play. The other major mechanism that underpins most of the manifestation in sickle cell disease is the breakdown of the red cell, what we know medically as hemolysis, leading to some other manifestation. So virtually every manifestation of sickle cell disease can be grouped into either, of this. So, going back to your question, so the acute pain crisis or the vaso-occlusive crisis is the number one, the most common form of crisis. But there are other forms of crisis in sickle cell. I think the next most common one is actually the sequestration crisis, whereby the blood actually pools in some organ of the body, usually in the spleen, which is an abdominal organ, or the liver. This commonly occurs in children because at that age the spleen has not shrunken. It can still accommodate almost the entire blood volume of the body. The liver less so because it's a bit more rigid for it. So another major form of crisis is what we refer to as a plastic crisis. This usually occurs when there is an abrupt stoppage of the production of red cells. And this usually occurs in the setting of some viral infection, most commonly a particular type of virus we call parvovirus, B19. It's a common cause of virus that causes flu, the common flu. But this particular type of virus, once it gets into the bloodstream, it can actually stop the stem cells in the bone marrow from producing red cells and can lead to abrupt reduction in all the cell count, not just only the hemoglobin or the red cells, including the white cells and the platelets are equally affected. So the fourth, and the last major form of crisis, some actually don't really refer to it as a form of crisis anyway, because it's something that happens almost every second in someone with sickle cell, and that's what we call hemolytic crisis, meaning that the breakdown of red cells. But why some refer to it as a crisis, although that goes on the background at a very low scale level, but there are certain instances whereby the breakdown of these cells can be much more increased, and that's why some prefer to refer to it as hyperhemolytic crisis, meaning that aside the baseline usual regular breakdown of the red cells that occurs in sickle cell, because the normal lifespan of red cells is meant to be about 120 days. But in sickle cell, the lifespan of the red cells is significantly reduced to about 7 to 10 days, and that leads to rapid turnover of the cells. So some refer to it as hyperhemolytic crisis because if there is an increased rate of breakdown of the red cells, the blood level can go significantly low and lead to very severe manifestations and complications arising from there. So those are the four main type of crisis we have in sickle cell.
Okay, so is it possible for one to have, like, say, a sequestration crisis and not feel pain? Would one, or a hemolytic crisis, for instance, or would one always feel pain if one had such a crisis?
Okay, so as we've actually mentioned, that the major form of pain is the acute pain crisis. So many a time, even when other manifestations or other complications do arise, it usually also happens in the setting of an acute pain crisis. So, to answer your question specifically for sequestration crisis, part of the manifestation is actually pain, because as the spleen does stretch and expand, in pulling the blood into it, it does induce pain. As we did mention, pain is actually a way for the body to point to that there's something happening here for it. So many of these other complications or other crises in sickle cell are usually accompanied by pain also. But the acute pain crisis is more of a pain syndrome majorly as the major manifestation. But these other forms of crisis have other features associated with them, but they cannot actually occur at the same time with pain crisis.
Okay, all right. Thank you for shedding light on that, because I'm always curious. You see some people that they say I have sickle cell and in 3-4 years I've not had pain at all, and I'm wondering, but thank you for that. So you've kind of defined the vaso-occlusive, which you call the acute painful crisis. So before we go to, my next question would be the triggers of the VOC. For in the layman language, it just means, for those that are watching, it just means the pain crisis. Before we go to the triggers, sometimes when I go to hospital, I hear doctors say acute pain, I hear them say chronic pain. I'm curious, what's the difference?
Okay, so that's a very good question. There are several let's say, complications. They are referred to as complications of sickle cell, and they are largely divided into acute and chronic complications. Of course, the crisis is actually the acute one. Acute meaning that something that manifests within minutes or hours, and usually, of course, with appropriate treatment, don't last for more than a few weeks at the most. Whereas chronic complications refers to long-term, effects on the body. So talking about things that could be there for months or even years. And the thing with sickle cell disease is that virtually every organ system, tissue of the body is directly or indirectly affected by the sickle cell syndrome, itself. And that's why it's important to note that despite the fact that acute pain crisis is the major form, of crisis, that, one can actually have some other forms of pain that we can term chronic pain.
Okay.
The acute pain is one that many times just triggered suddenly, but some people do experience a more like a pre-phase of it, a prodromal phase. It's even likely classified in terms of the phases of pain crisis, the acute pain crisis, into the prodromal stage, which is like the more like the premonitory stage, something that once some people can tell in their body when they are about to have a crisis. Okay, then the actual established, crisis, itself, then when it's resolving, in that manner, really. So acute pain, actually, the vaso-occlusive crisis or the bone pain crisis is a form of acute pain. But there can also be some chronic pain syndromes. Some people, even when they may have continuous headache for weeks or even months, while others could have some, because there are some may go a bit into the fine details here, because there are some pain syndromes that are actually modulated by some areas in the brain. So in sickle cell, what we call the central sensitization syndrome, in which there is some triggers of pain, even when physically or on the body itself, one may not be experiencing pain, but there are some triggers in the brain. So acute pain complications are, of course, the most common forms of painful syndrome, but there are some chronic pain syndromes that are associated with sickle cell disease.
Okay. Thank you, doctor. So for those, I know some people just came in. For those that are joining us, Dr. Adelabu just told us the difference between acute pain and chronic pain. Okay, now I'm going to ask, my next question would be, you've already defined what the acute painful crisis is. You said it's what we also call VOC, vaso-occlusive crisis, and you said that it can be brought by, well, two main things, occlusion or hemolysis. Now, what are the triggers of a VOC? And is it possible to have a VOC without a trigger?
Yeah, absolutely. That's a very good question. So, of course, with research and also even with anecdotal and personal experiences of people with sickle cell, quite a number of triggers or precipitating factors have been identified. That usually lead to the development of these acute painful episodes. The first most common, particularly for us here in sub-Saharan Africa, infection is still the number one form of trigger. Of course, an endemic type of infection in our environment is the parasitic infection called malaria. Because malaria parasites is virtually everyone that lives in this part of the world have been exposed to the parasite at one point in time or the other. And there is always that possibility of recurrent infection. And in fact, there are some resistant strains of it that are difficult to clear from the body system. But not only malaria infection, any type of infection, be it a bacterial infection, a viral infection, a fungal infection. Because what usually happens, most infections usually come with fever. With fever, there is dehydration, which we'll get to as this. So many effective processes do have features in them that triggers the process really. So next to that, first being infection, the second most common trigger is dehydration. Of course, we are also living here. For those of us who are in the tropics, of course, it can be some time of the year can be really extremely hot, and the weather could be extremely hot. and then lead to dehydration or inadequate intake of water. So dehydration, generally. The one that would go with that, which I just even mentioned in terms of the weather, is extremes of weather, because it's not just only becoming dehydrated as a result of the hot weather. So whether being exposed to too hot a weather or too cold a weather, because the changes in temperature does affect the amount and level of sickling in the body, and that goes a long way in triggering a painful episode. So extremes of weather. Yeah. Then stress. So when we talk about stress, of course, it can be in form of physical exertion, but also psychological or emotional stress has also been shown to uh, be one of the triggers of pain crisis in the body. So those are the major ones. But there are some times in which, having even explored virtually all of these possibilities, we might not be able to find a trigger. There are some few episodes that one may not be able to identify specifically a particular trigger that would have started up the entire episode. But it's important to still manage, to look out for all of these triggers, and then also to see how to eliminate them.
Okay, thank you. I was smiling because when you were talking about the stress, you said physical, emotional, and it made me laugh because I remember when I just got married. So it's years ago. I would argue with my husband. Honestly, I would have crisis later. I'm like, what's the matter? How can I be arguing with one man that is not feeling pain? At the end of the day, so it's me that will have that will have crisis. So much just because I would charge it up emotionally. So I now realized that my emotions are actually connected to my health. Was later that I realized that sometimes if I hear a sudden news, I don't know, I begin to feel pain. So after, well, as as you age now, you learn how to manage those things. So later I'll just be like, what, I'm not even arguing with anybody. I'm not even getting upset or anything. And so yes, emotional stress can trigger crisis. Thank you for that. Okay, so I don't even know my questions. I don't know the next question to ask. So now what are the classes of the painkillers? The ones I know the NSAIDs, I know the opioids. I don't know if there's any other thing, but can you just explain to us what the classes are and the mechanism in which they work, and maybe how they attack pain?
Okay, so like we mentioned before that there are several aspects of pathway, pain pathway, but I don't want to go into the medical details of it. So there are several pain medication which we refer to as analgesics, the thing that actually nullifies pain. Based on what we know scientifically in terms of how pain is interpreted in the body and how pain manifests in terms of how the body gets to feel it or to experience it. Medications have been developed that can block the pain pathway, if I can use it that way. Because in sickle cell disease in particular, if I had to take that as a specific example to explain how this pain medication works, is that during those occlusions leads to a series of processes around the cells and the tissue. Part of it is what we call inflammation. In inflammation, there's some tissue damage that leads to release of some materials from there, and that is what triggers the nerves. Because we feel pain sensation because they are actually what we call sensory nerves. From it. So the nerves that carry sensation are what we refer to as sensory nerves. The one that bring impulse or bring a signal to the part of the body to move at the motor nerves. So the sensory nerves are the ones that do carry the pain pathway itself. So the various classes of drug, include what we call the non-steroidal anti-inflammatory drug. That's the one that is abbreviated as NSAID. Of course, that's where you have your diclofenac, your ibuprofen, piroxicam, and drugs in that category, because they help to reduce that inflammation I described about, that usually, and they are quite a very effective group of pain medications that can be used. Now, the opioid medication, because even though the sensation is carried from tissue level through those sensory nerves, as I mentioned, so those NSAIDs will help to reduce that inflammation. So to stop the transmission of the impulse or the signal from the cell to the brain. but it's the brain that interprets it. Okay, and so there are a number of connections in the brain related to the pain pathway, and that's where the opioids come in. The opioid medication, because there are some chemicals, we'll call them transmitters, neurotransmitters, that transmit the signal through the nerve for the body to interpret it as pain and points out to the body that something is happening at this part of the body. So the opioids are medication that they actually work at the level of the brain to block that passage of the signal from the body for the brain to interpret. Because if the brain doesn't interpret it, the body doesn't sense it as pain, even though there is a trigger from the at the nerve level. So that's where those other pain medication do come in. So many medication either acting in the periphery, what we call at the nerve level, or at the central level in the brain where it is interpreted. Of course, one other group of pain medication that may not fit into either of the pain category, but it does a similar thing, is the a regular paracetamol or Panadol, either as it's where it also does work in a similar way to the NSAID, but it's not in reducing inflammation, just in reducing the level of firing of the nerves, but not by reducing inflammation happening there. But of course, it's not a very strong pain medication, unlike the other two categories. If I could say, in terms of the level of how potent they are as painkillers, the paracetamol or Panadol will be in the lowest level. Then after that, the NSAID, and of course, the highest level are the opioids. Yeah.
How I wish all the nurses in the hospital will hear you saying that paracetamol is at the lowest level, because you will go to the hospital crying, I'm in pain, and they'll be offering you paracetamol. And they will offer you paracetamol tablets. I'm like, oh my goodness, I have paracetamol at home. If I wanted paracetamol, I won't be coming here. But yes, thank you for saying that. So we have the non-steroidal, the opioids, and the one that doesn't really fit into both, which is the paracetamol. Okay, thank you. So you basically defined it for us. So doctor, I want to ask you a question. So now you said non-steroidal reduces the inflammation. So we can say that it is LP. However, for opioids, you did say that it intercepts the signals in the brain. Is that why you go to hospital with a very bad crisis? They give you a dose of maybe pentazocine for those in Nigeria, or maybe oxycodone for those in the UK, and you feel a bit relieved. And when the pain comes back, it's like it is double. You're like, but they gave me some medication 2 hours ago. Is it because the thing has cleared and really the source of pain is still there, but the job of the opioid has cleared? So it's like it comes back and it's even worse. It eats you like you didn't even take anything previously.
Okay, Ali, thank you very much. Ali, this will make us go into the topic itself, the pain management. There are a number of things that we look at in terms of what type of pain. So starting with the pain itself, maybe one thing we have not talked about before is that there are actually different severity levels of pain.
Okay.
Okay, so pain can have a mild pain, moderate, severe pain. Because pain is a subjective parameter. In fact, there's no test in the world that can diagnose or that can confirm that someone has pain. It's what the individual tells you, because it's only the individual that can. There's no machine yet developed or any test developed yet that can help to identify that this person is truly in pain. And so, it's largely dependent on the individual. And that's what we use in terms of trying to get a semi-objective form for it, is to ask for the pain score. Of course, with the pain score, we're able to classify the pain into mild, moderate, and severe. And that's also now detect the type of pain medication that should work for that condition. But knowing, just before I go further, but knowing that identifying the trigger and treating it and eliminating it is what would eventually lead to the pain going away. But the pain medication is to give relief till the entire crisis does resolve completely. And so that's why, as you mentioned, of course, there's also a place for home care management for pain. So it's not less than 50% of pain crisis, would lead to the individual going to the hospital. many people have, some mild pain that they actually get to treat and manage by themselves at home. And that's why, usually we give some medications to have at home to use, in the first instance. It's only when that doesn't really help so much with the pain, it's becoming more severe, and then, person should present to the hospital. So mild pain, which generally is on a pain score between 1 and 4, and between 4 and 7 is like a moderate level of pain, and 7 to 10, because the scale is from 1 to 10. That's in the adult. But for children, they actually use a visual scale where they can actually say how much or the level of pain is. But if you have to take the adult as an example, it's in that category. 1 to 4 is mild pain, 4 to 7 is moderate pain, and 7 to 10 is severe pain. Now, for mild pain, that's where paracetamol can come in the first instance, really, and or the use of NSAIDs. Okay, that's the non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, piroxicam, and the likes in that category. Then, of course, for severe pain, the opioids are indicated. And now when it comes to who gets what at what instance, and that now goes with your question in terms of that, if you now give the opioids that are actually blocking the pathway in the brain, that once that wears off, it gets to come, up. And that's why we tend to not use just one pain medication. So we tend to use pain medication that can block the pain pathway in more than one aspect of it. So there may be a combination of both paracetamol and NSAIDs, or NSAID and opioids, or even use the 3 categories together. By the way, I didn't get to mention that even within the opioid categories, there are different level of efficacy of the opioids. Okay, starting going from morphine to oxycodone, as you mentioned, to pethidine, to fentanyl. There are several different opioids, basically, that are used. Of course, in this part of it, we don't have all of this. We tend to use more. Pentazocine is not really an opioid because it blocks the pathway. It also stimulates the pathway. So it's like almost like a semi. Well, maybe if you have time, we can go to a bit more details, in that. But the major opioids are the morphine, cospecidine, whether morphine or diamorphine, if it's available. Of course, in this part, we also have fentanyl. At least in some tertiary centers, use fentanyl medication, and of course, we have the tablet form of opioids too, the dihydrocodeine, what we refer to as the 118. When it comes to hospital management or care of the pain, in patient category, there are 2 patient categories that also needs to be put into consideration. So we have some set of people that have never been exposed to opioids before. So those we refer to as opioid naive. And those that would have had opioid in the past. So those that have actually have opioids in the past before. Because that determines the level of pain medication that will be given. So someone that had, say, oxycodone to have at home to use whenever there's pain, or even maybe tramadol, or any of the others, if there, if there is an acute pain full crisis or episode, of course, it's very unlikely that that same medication would work in hospital. So one has to go like a step or a level higher to be able to achieve control, because the main aim, or the first main aim for management of acute pain crisis is to give rapid and effective pain relief. It means that those that we can control their pain from the time they get to the hospital, if the pain can be controlled, preferably within the first 8 hours, but at the most within the first 24 hours of presentation, actually, goes a long way in not only improving, because the pain also have a major psychological impact. We may have time to get into some of that, and that's why it's important to get to control the pain early. So it's good to actually even go for the higher, because most pain that would bring the individual to the hospital will be from moderate to severe pain. And so that's why it's indicated to give the opioids, at the very beginning. But just so that I make sure I complete the answer to your question, in that, because those medications are centrally acting, the opioids, so if, for example, one is just only taking opioids, and the underlying trigger is not well yet effectively addressed and it's still ongoing, when the effect of the opioids wears off, it will now appear as if the pain is coming much stronger because
Mm.
out from the periphery or from the hand or wherever the pain is originating from and being sensed at the brain, it has just been blocked for those times. But once the blockage goes, it keeps firing in the brain, and that's why it may appear as if the pain is much more than that. But most time, if one use a combination of the pain medication, so blocking it in different pathways, one is unlikely to have that effect, if it does get to that at all.
Okay, all right, thank you. I will just read some of the comments. Cynthia said I was in pain, almost 8. I think you mean level 8, and was given paracetamol. I was so mad. One nurse was telling me I am a woman and I should bear the pain. Men, Nigeria is finished. Okay, thank you, Cynthia. People says, imagine that. Obaro says, Obaro 358 says, you've been a genius right from high school. I think that's someone that knows you, doctor. Says, you were the best student then at Birchman, Freeman, Surulere. PP says, yes, once the pain can be arrested early enough, it helps a whole lot. Okay, thank you, doctor. So back to, thank you for the comments, rather. Back to my question. I was going to ask about the cocktail, because you hear some doctors saying that, oh, we have to give a cocktail of pain medication, or we have to stagger, So I wanted you to explain what you have. That was when you spoke about, sometimes you need to give the different types of the medication for it to go. Okay, so I'm going to ask, my next question would be managing the pain at home. However, I wanted to ask a question. So you see an individual that says, oh, or somebody that says my daughter or my child has been in the hospital for 2 weeks, 3 weeks, and they're not getting better. And what then do you say to that, or what then can we do? Because this is somebody that has been in hospital, that has been given probably all the pain meds that the doctors can lay their hands on, and it's still not getting better. So what is it that they are not treating the source, or this pain just refuses to go? That's the first one. Then the second one is, how long can pain stay? Because I some people will tell me, I left hospital last week, but I'm still feeling the pain. Even I go through it as well. And I've left hospital, but there would still be this nagging pain that it doesn't completely go to zero. So, like, how long can that continue for? And, I don't even know the question, but I hope you understand what I'm trying to say.
Very much. Okay, so let me answer the first part of your question, which is in terms of the pain medication to use at home, and really, of course, if someone is having pain, even while being in the hospital for 2 weeks, the pain not. So part of the recommendation in the guideline. Okay, by the way, let me start by just even referring to one of the comments you read out, because part of the issues when it comes to pain management in sickle cell in Nigeria is that even some healthcare professionals, are not aware of the right thing to do. For several years ago, Professor Kehinde and Dr. Ibidapo did a study in Lagos here. That was, it was published in 2002, whereby they actually sampled, doctors, medical doctors in hospitals, different hospitals in Lagos, about pain management, in terms of. So that study revealed that only 70 to 80% at that time of doctors actually even knew, what to do in terms of offering opioids as one of the first line medication. And when they went further in that study to find out, okay, what were some of the factors that actually determined the analgesic choice? Some, were afraid, we didn't want to give opioids because either they feel that the patient will become addicted to it. Some it was because it was not available, in their center. So this is actually like almost a 20-year-old study. And part of the recommendation there was that there should be a guideline, a protocol that people follow. And through the National Sickle Cell Center, Sickle Cell Foundation, there's actually a national guideline for management of sickle cell disease, which many healthcare professionals, because it's not just the guideline is not even majorly for hematologists, for virtually all healthcare professionals, because hematologists can't get to see every sickle cell patient, even when they have an acute painful episode. And that's why it's important that every healthcare professional actually knows the basic minimum when it comes, to that. And this can go a long way in actually taking care of this. Because part of the recommendation, now to your question in terms of how someone could have pains for weeks, without being fully addressed. I mentioned that identifying the trigger is very important. So of course, there is a typical presentation of the acute pain crisis, but many times there is an identifiable trigger, and that needs to be addressed. Part of aside from pain medication, a very important aspect which many doctors or healthcare professionals may not be doing rightly is the use of the intravenous fluid. That's what we call drip in Nigeria, in terms of having to give the fluid, because that also is a form of pain management. Giving the adequate fluid, hydrating, has been shown to significantly help control the pain. So it's not just about pouring pain medication. If you are not giving the right fluid, and not giving it at the right frequency, managing or controlling the pain may be a bit difficult. But it's important, as part of the recommendation too in the protocol, that aside from identifying the trigger, there are some causes of pain that are not just only from acute pain crisis. There are some pains that are what we term musculoskeletal, that is arising from the muscle or the bone. So someone that has osteomyelitis may be having pain. The pain may be there for even much longer. Someone that's having arthritis, because there are some, there are several causes of pain. There are conditions that are associated with pain. As I said, pain is just something to point the body to a particular area of the body. So someone can have arthritis, other causes or anything. Having sickle cell disease does not completely insulate one from some other condition that actually every other person to do get. Okay, because one can even have an injury or anything. So those things should be investigated, to be looked into, particularly if the pain is lasting for weeks, having given virtually every thing expected to be given. So use of opioids, NSAID, giving adequate fluid, identifying the trigger and all that. If the pain persists longer, or if the pain is in any way atypical, meaning that it's not the usual, there's a usual pattern of the acute painful crisis. The pain may seem to be moving from one part of the body to the other. It usually affects the long bones and the back. That's the characteristic bone pain crisis. But if one is not having pain only in one particular spot, because there's also what is a medical term, I'm using to, is the osteonecrosis, which is like dissolution of the bone. If the occlusion in that particular spot of the bone has stayed too long, that part of the bone can start becoming, let me use the word in quotes, dead, and that can trigger a lot of pain in that spot alone. So when it comes to the management of it, several things can be done. We would get to that. So for the second part of your question, in terms of maybe home care, as in what one can use at home, and even what other things could be associated, with the pain, all true. Part of the evaluation of, the what we call health maintenance for sickle cell disease is, of course, to have, regular checkup, because it's not only when there is an acute pain crisis, really, because part of what we're expected to do when you come for your health check or the appointment, regular visits, is to even ask about the pain episodes that may have occurred in between the last visit and the current one, that may have been managed at home. And that can help give an idea of the overall health of the individuals. And of course, that can be an avenue to also get to identify some of the common triggers, and maybe provide some recommendation or suggestion in terms of what to do to avoid future occurrence. Because avoiding the precipitant also goes a long way in helping. Because the more one is able to reduce the number of crises, the better the overall health. Because every time an individual with sickle cell disease have a crisis, aside from the bone pain that is experienced at that time, it leaves some residual effect on the organs of the body. Because those cells that have those cells that are plugged the tiny blood vessels in the body, leading to the pain, are also affecting the organs of the body. They're affecting the heart, the kidneys, the lung, the brain, and the liver and the likes. So it's important to reduce the frequency of the crisis. And that's why maybe when we get there, shortly, that one of the first set of criteria for the use of hydroxyurea when it first came on board were to give to those that have 3 or more major bone pain crises in a year, because that having such number of crises usually leads to organ damage over time. So I hope I answered most part of your question.
Yes, you did. Thank you, Dr. Adelabu. So the managing pain at home. So I wanted to ask, what are the other things a warrior can do to manage pain at home that doesn't involve actually taking analgesics?
Okay, that's a very good question. Regarding part of what we mentioned was that of the triggers is extreme of weather. Because many times, if say, of course, now with the climate change and all that, because even in Lagos this time of the year that should not really be rain, we still having very heavy rains, flooding everywhere, for it. So many times, particularly, the best time to really even stop the pain from progressing any much further is when it starts. At the very beginning, once some people can tell in their body when they're about to start having a bone pain crisis. And so, say for example, you already know that maybe, depending on, part of the physical or emotional stress we talk about, and that's why it's shown that in childhood and early adulthood, and that's when the crises are usually more. So anybody above 40, the rates of or the number of episodes of the crisis usually reduce from that age. We have even students from the stress of university students, the stress of exam and all that could have that time. So when one notices that, okay, say for example you're even working and maybe you have some assignments or some things to handle at work and you're already being stressed up and you can feel it already coming. Of course, part of the thing to do is, if possible, to find a way to take some rest.
Okay.
If it's extreme of weather induced, say in cold weather, to put like on a body warmer or a sweater or something, because that at the early phase can help. The use, particularly if it's limited to some parts of the body. There are some pain medications that are not as either tablets or injection. They are available in gel form.
Topical.
Like, for example, diclofenac, what we call topical agent, like diclofenac. So those are also part of what one should have at home, and then can apply on those parts of the body, particularly the limbs, when one, is experiencing pain. For some, type, of pain, the use of, some actually think, feel that it does work well for them. Some the use of hot water bottle. At times you may even need to use some cold compress. There are some joint pains that a cold compress can, help with majoring. But it's actually good to still, in addition to all of this, to still take some pain medication, because it's been shown that when the pain is still at the very early stage, not in the severe, maybe still a bit mild, taking pain medication at that instance, and of course, trying to identify the trigger. In this part of the world, because we know malaria, even if malaria, part of that study that I even mentioned that having healthcare professionals know that as part of the management of acute painful crisis, in addition to giving the adequate fluid that in form of drip or giving the medication, is to treat malaria. Whether it is there or it's not there. Of course, you still run the test, but it's good to actually give the analgesic there. So those are some of the other things that can be done as part of the home care management of the painful crisis at home, basically.
Okay. All right. Thank you, doctor. So I'm almost done with my questions. The other question I wanted to ask was, as a hematologist, what would you advise sickle cell warriors watching about going into hospital? So at what stage would you say this is the stage you go into hospital? Because we know the truth is that some people try and treat. So this is even for everybody. They're not only Nigeria. I myself, that I'm in the UK, There are times that I'm like, I can't even afford to go into hospital. I have to do this. I have, So there are so many reasons why people don't go into hospital.
Yeah.
Aside the having cash to pay for those that live in Nigeria and that pay out of pocket, maybe they're not on insurance. So what do you advise about when is the right time to go into hospital? Because you see people saying I've been managing this pain at home for 2 weeks. Some will say, I remember somebody that said, oh, I know somebody that has had pain in their knee for 3 months. And I was like, 3 months, have you gone to check it? And they said no. So what would you advise warriors about managing pain? How long is enough to manage your pain at home yourself? When should you present to hospital?
Okay, thank you very much for that. I may not be able to put, of course, because individuals are different and all that, but I'll put like a general, recommendation or suggestion, regarding that. But first, to mention, that from the first part of your question in terms of even hospitals to go, what I usually even advise most of my patients is that aside from you having an hematologist that follows up on the long term, that you have regular visits for once every 3 months or 4 months, for an health maintenance checkup and all that. You should also have, depending on where you are based at that point in time, if not relocated to any other part of the town, you should have an hospital close to where you stay that you can always go. But we know that in Nigeria, there are hospitals and there are hospitals. Okay, there are different types of hospitals. Definitely, of course, if our healthcare system and the structure is right in terms of that, for there should be like a proper referral system. Many a time people want to go because that's where the specialists are centered in the tertiary hospital, but there might be delays, there might be bed pressure issues in terms of being able to be attended to early enough and all that. That's why it's important that even non-hematologists should be able to at least give the first set of treatment that is required, and only in some cases that might require a referral to a specialist center, if need be. So it's important, for everyone with sickle cell disease, particularly in Nigeria, to identify a good hospital, closer to where they stay, for emergency purpose, and if the pain starts in the middle of the night or something that you may not be able to go to your regular hospital where you see your hematologist and follow up, regularly with. So that would be the first part of the answer to the question. The other part in terms of like when should you go, how long should you, use the home care treatment before downside to go to the hospital. It depends on the severity of the pain. So once the pain is still in the mild, to maybe early moderate levels, that can still manage at home. But remember I mentioned that the pain medication is not the only aspect that is required in the management. So the fluid aspect, of course, if you're not having any fever or you're not vomiting or from any infection or anything that could be a trigger for it, of course, aside from the usual recommendation of taking adequate amounts of water daily, one may need to take even more than to ensure that one is well hydrated. Then one should avoid extreme of weather. So whether it's cold, to have sweater on, whether it's hot, to ensure that one puts on a light clothing, and all that. Then, as I said, even regardless of doing the malaria parasite test, to have adequate treatment for malaria. Of course, part of what we do prescribe, here, because being in a malaria endemic region, we give some prophylactic or preventive medication for malaria, but that doesn't 100% prevent one from having malaria. We know malaria is transmitted by an insect bite from the mosquito. So avoiding exposure to the insect bites, either in what we do with the environment to make sure the mosquitoes don't breathe there, or that use insecticide treated nets, or in the evenings, to ensure that one wear well-fitting clothes that would not expose most parts of the body where the insect will actually bite and then transmit the malaria infection. But the use of the prophylactic medication, usually we use the Proguanil or the Paludrin, daily. But even despite the use of that, it doesn't mean that while on his one would not have or would never have malaria. But part of the advantage it does give one is that even when one does, come down with malaria, it reduces the severity and also the frequency, of it in the body. Because at times, even those that without sickle cell do come down with malaria, even without a recent insect bite or mosquito bite, because we all in this part of the world still have some level of the parasites circulating in our body, and in the right setting, whether we're stressed up or we're in one way or the other, there can just be a
Okay.
more like a resurface of the malaria parasite infection in one system, even without a new or recent mosquito bite. So going to the hospital, determining when to go to the hospital. If one, aside from the pain, if one is having a fever or having other symptoms, maybe vomiting or diarrhea or a cough or anything, so that will not be the one to manage at home, because aside from taking all the measures we've mentioned to help control the pain at home, there are other things the individual will require, because there may be a need to have an antibiotic course, which the person may not be able to know what to use. But in the first instance, what one can do at home, aside from taking the pain medication and all those other pain control agents we discussed, and adequate hydration, taking a lot of water or fluid by mouth, and then also is getting enough rest and treating malaria. Of course, malaria medication is an over-the-counter medication here. You can always get that. But aside, once one does those three and the pain does not abate, after a few days, I don't think one should wait till up to a week. It's important and necessary to go to the hospital so that other forms of intervention can be instituted early enough to ensure that the pain doesn't linger, the crisis doesn't linger for too long. Now, for those that are having a particular joint pain for months or weeks, that doesn't go in the line of acute. We define acute and chronic. That's in the realm of chronic pain. And for that, that's not one to treat at home. One has to go to the hospital. There may be need to do some x-rays. Some may even need MRI, because the hip pain, you are thinking that may be part of the bone pain crisis, may actually be what we call AVN, the avascular necrosis of the thigh bone, particularly the head of the femur bone. Or a knee pain might even be from either osteomyelitis or even arthritis, or might even be a form of arthritis called septic arthritis, an infected knee joint, with maybe coming some swelling and the like. So I think that's kind of like a raw general guideline in terms of it. It still needs to be individualized a bit, but at least if one sees those pointers, then one should go to the hospital early enough. But otherwise, having taken those measures and there's improvement, then that can be cleared at home.
Okay, thank you. Before I ask my next question, I'll use myself as an example. So October of last year, I don't know if you heard me when I started. I said I fell on Wednesday. I fell.
Yes, yes.
So October of last year, I started to have this. I noticed this pain in my right knee. And I would put my heat pad, I'll put my hot water. But if I was so bad that the skin that changed, and my hematologist said it's from constant heat. I'll put my heat pad, I'll put my hot water, I'll use my CBD balm, I'll use everything. It wasn't going, and I kept saying it was crisis. Well, later my husband said, I don't think this is crisis, because crisis for this long isn't. So I went for one of my transfusion and I mentioned it to my hematologist, and they said, if it's crisis, it should relieve you in a few days after this transfusion. But if it doesn't come back. So I went back. It didn't, so I went back and he said I should go for an x-ray. I did the x-ray. X-ray was normal. And I said, let's go for an MRI. We did the MRI. MRI showed that there was fluid in the knee. So imagine if I kept saying it was crisis and crisis. So I did the MRI. MRI said there was fluid in the knee. So my hematologist said, now I have to refer you to the orthopedics. Meanwhile, in the meantime, take some oral steroids to make it go down. I did a course of steroids, but it didn't totally take it down. And then I had to go in for them to take out the fluids. Anyway, long story short, they found out that they said there's something called synovitis. And then my doctor now said a lot of infractions based from different sickle cell crises, the knee has already been affected, So now they are treating me for the synovitis. So I think that's what it's called, synovitis or synovitis. I don't know. So I go for the injection. They inject steroid in because the doctor said he would rather just manage it rather than taking me for a surgery,
Surgery.
And it's been okay. I got my last steroid injection in the knee in August, sorry, and I was fine. If not that I fell on the knee on Wednesday, just on the outfit. So I think that was what made it flare up again. So
Again.
sometimes you really do need to um check out, investigate that pain. Now, what I wanted to ask again was we've mentioned the type of the pain medications, but I forgot to ask for the pros and the cons. Now, the reason why I said this is because again, some months ago we talked about sickle cell nephropathy, and one of the persons that spoke is on dialysis, the sickle cell were on dialysis, and he said that he believes that it was how that he believes at a point he abused the non-steroidal medication. So non-steroidal, for those that don't know, are like ibuprofen, diclofenac, piroxicam, bufelvin type of medication. So he said he believed that that was what really affected him, because I think he was having AVN and was always using it. So the truth is that as much as these medications have to give us relief, there are also some cons. There are some, pros and cons. So what are the pros and what are the cons? In case somebody is watching and saying, oh, okay, oh, doctor has said opioids are good and you want to go and overload yourself on it. So what are the advantages and the disadvantages of these classes of pain relief?
Yeah, thank you very much. That's a very good question. We've talked about the various type of classes of drugs or medications that can be used for pain control. And so they don't come without side effects and even some contraindications. Of course, to start with, the group you mentioned, the NSAIDs, the diclofenac and the likes for it. And that's why even in the guideline, the recommendation for it is only to be used for those that do not either have significant previous side effects from it and or contraindications. And what are the ones that are referring to? If I could take the case study of the individual you mentioned in terms of affectation of the kidneys. So NSAID, chronic use or long-term use, because it doesn't mean that after hearing this you never use NSAID again. No, that's not.
Yeah.
So it's a long-term use of NSAIDs, drug in that category, can lead to some kidney problems. But it's also important to know that sickle cell disease itself, even without the use of NSAID, can lead to some kidney issues. And that's why, this medication needs to be given under some guidance and somewhat in terms of like following up with the use of this and knowing when to use it and when not to use it. And that's why when we do prescribe, we usually prescribe for a short duration of time. Opioids can be taken much longer. We'll get to that in terms of their own advantage and disadvantage or side effects and complications. But starting with NSAID, the kidney issue associated with it, long-term use of it, so we only prescribe it for a short duration of time, and that's why there's also a gel form which can now be applied topically, that it can be rubbed on the skin, that can give similar effects. But of course, either the injection form or tablet form, usually more effective, but even the one that is applied on the skin is also effective to an extent. Another major side effect or complication from use of NSAID is actually the development of what we term medically dyspepsia, but that involves or includes things like ulcer. Many people in Nigeria use the word loosely that, oh, I have ulcer. When they have some abdominal pain or discomfort, which can be from a lot of things, because we know in sickle cell, even abdominal pain can be caused by gallstones, stones in the gallbladder, can even be caused by some issues around the pancreas. The pancreas is an organ in the abdomen that produces some juice that help us digest the food we eat. It can even be in form of a crisis, that there can be vasocclusive crisis involving the intestine, the small intestine, that can cause abdominal pain and the legs. So those are effects from sickle cell that can cause abdominal pain. But long-term use of NSAIDs like diclofenac, ibuprofen, and all that, can cause some ulcerations in the stomach, meaning that it will cause some type of injury in the stomach wall. Because the use of it prevents there's a usual layer that protects our stomach and intestine, from the food and the acid that the body produces to digest the food, itself. But the use of medications in that category more like stops that layer from developing, and then can lead to injury or can lead to ulcer or a wound developing in the stomach. The consequence of having this is that that can now lead to some minute amounts of blood loss, which can accumulate over time and further reduce. So we've seen quite a number of people with sickle cell disease that usually have some pain syndrome or pain complication using this NSAID. And then you just notice that their PCV keeps dropping. Maybe they use maybe of 25%, that's the hematocrit level, and keep dropping. So usually the first two things we want to exclude, particularly if they've been a chronic use of NSAID, because affectation of the kidneys can lead to reduction in the PCV level, aside from affecting the kidney function, because the kidney produces a very important hormone that helps the body produce the red cells. And
Oh, wow. Yeah.
with those with sickle cell disease with kidney issues, the PCV are usually extremely low. Though the body is able to cope with it, but after a particular level, after a while, may not be able to cope and they may require transfusion and the likes. The other way that use of NSAIDs, aside from affecting the kidneys, the other way can affect the PCV and bring down the PCV is if it causes one to be losing blood gradually over from the stomach. And that is why many times when we prescribe the use of this NSAID, we usually prescribe it by giving a medication that helps to reduce the amount of acid building up in the body, in the stomach. We call omeprazole and drugs in that category. Rabiprazole, esomeprazole. There are even some formulations of these NSAIDs that already comes with it already combined in a single tablet. Things that would ensure that the NSAID does not affect the stomach. There are some combination with cholesterol. I mean, there are some formulations like that. But the usual formulations come as single medication. So one may need to use it alongside medication that can reduce the acid production in the stomach, or even the use of some antacids, some of those liquid stuff that has something that can neutralize the acid in the stomach.
Okay.
So those two are the main, side effect or disadvantage of using NSAID. Even though NSAID are very effective pain medication because they reduce inflammation, which is usually the underpinning process or mechanism for the development of the pain syndromes. So as for the opioids, that's where that one is a bit different. Some people react to some opioids. For example, say tramadol, for example, some people cannot tolerate their intolerance of tramadol. It can induce vomiting for them, so some people are not able to take it. Some other opioids usually cause a lot of itching, body itching for some. Though that one is not, unless it's very severe, but there are medications that are also given with the opioids to help with the itching. That can be given, unless it's really so bad, despite every other thing, that one may now not be able to continue the use of the opioid. Now, of course, there's always that fear of dependency issue, in terms of use of opioids. Some also, but whenever they take some opioids, it makes them really extremely drowsy and sleepy. Because it works in the brain, it has that additional effect. And of course, one has to be careful in not taking an overdose. Because overdose of the medication can suppress one's breathing and can even make one go into a coma. So these medications have their pros and cons, and that's why one needs to be guided in their use, with one's doctor, the hematologist, in terms of and it's good for what I usually tell my patients that it's good to be open about the use of the medication, because individual have different. I know a particular patient that paracetamol even cause headache for her, so just need to take NSAID. Of course, she has this patient, I can't take it. The only medication she can take is tramadol, because almost every other thing, unable to take it. Even the hydrocodone, therefore one it even does not even help with the pain at all. And when you usually get morphine or the other ones, cause a lot of itching. So it's different. Individuals have different characteristics and preferences based on their body makeup. And that's why it's good to be open to one's hematologist or physician, and thereby now say, okay, what works best for that individual at that point in time. Very important.
Okay, thank you, doctor. Thank you so much. You've really done justice to this. So Dr. Adelabu has told us that there are cons to this thing. You can't just go and buy medication over the counter and just abuse it, or because you don't want to go into hospital, you're not going to overload yourself. There are cons to this thing. For me, I react to morphine, the
No.
itching out of this world. They don't even give me. They don't even give me morphine. And I know somebody that says when he takes tramadol, he has hallucinations. So what? And that's again one of the reasons why. Let me just say it here, because even though we are discussing, some people would say, "What's that medication that you said works?" Because they are planning to go and buy it. You can't say because I said A works for me, you want to go and use. You don't know if you react to it, so you have to be careful. Some of these things are best taken in hospital environments where if you had a reaction or something, they can easily manage you. This brings me to this I don't know if it's a comment or whatever. There was when I was having severe acute chest syndrome, I never even knew that there was a medication called fentanyl. All I knew was tramadol and pentazocine. I didn't know that there was even anything called fentanyl. But this pain, if I say I should, maybe the level was 2,000/10 because the pain was going to kill me. And then the doctor said we have to give you fentanyl. However, we cannot give you in the ward. You have to be in the ICU because some of these things are that's serious that we need to be monitoring and all that. So what would you say to people that just go to a small hospital, or for those that are not in the UK, and they just go to one small hospital and they're giving them opioids and all these things, like you said, even it can affect your respiration, you can affect your
Your
breathing.
baby.
All those people that will give you severe big opioids, but they don't put you on all those things that can monitor you.
So that's a challenge, really, and that's why it's advocated, like you mentioned, for even aside from giving, for many times how we give the opioids here in Nigeria, we give it in boluses, meaning that we give it maybe every 2 hours, every 4 hours, depending on the pain levels and everything, But as you mentioned, so like fentanyl is 100 times more effective than morphine.
Okay,
But
yeah.
the duration of effect is much shorter than the morphine lasts longer in the body than fentanyl. But fentanyl is much more effective in controlling pain than morphine. So many a time when fentanyl is to be used, it's usually deployed with a device called PCA,
Yeah.
patient controlled analgesia, whereby the machine is set in such a way that you can give yourself extra doses, but it is capped to a
Yeah.
particular
Yes.
level that no matter what you do, you cannot give more than a preset level. And then there's some set level that will continuously be delivered into the body system. It's a very effective way of controlling pain if it has eluded virtually every other step that would have been taken, prior to that. And that's why it requires monitoring of the vital signs, monitoring of even some body parameters and all that. So my advice for those that, of course, now like in my center, we do have the PCA. Some, of course, that's part of the, let me say, the development or things. Particularly in Lagos, we know we still have a long way to go, but we
Yeah.
are beginning to have at least I can name 4 or 5 big hospitals, recent hospitals that are maybe improving the practice in terms of course, there's still cost issues related to this. How many people can afford it? Some majorly in the island, some like the mainland and all that. For it. So, and that's why we still do a lot of improvisation. Many small hospitals, we still able to more like improvise in a way. But what we usually advise, even those of our colleagues, that when you have a case that is of that level, of that nature, it's best to refer to another center, because if you've done most of the basic and if you are to step up the level of care in terms of what you'll be giving and you do not have the required facilities to monitor effectively, rather than start and then put the patient life in jeopardy, it's always good to refer to center where you know that they can actually take it from there.
Yeah, I always tell my group members that A good doctor is the one that knows the time for a referral, because you cannot, you need to be able to say that this one is above me. Augustinuka says, Doctor, my daughter was given flucloxacillin. Flucloxacillin. I think I don't know that particular medication. I'm always mispronouncing it. 500 milligram for infection. That was like 16,000. I think she means her white blood cell was about 16K count. After the first dose, she started itching her body. I had to stop it, and she was given loratadine and prednisolone. Okay, thank you. So, Tinuke, are you asking the doctor what else you can use instead of flucloxacillin, or what? Do you have a question, or doctor, what do you have to say to that?
Yeah, flucloxacillin is actually an antibiotic, so it's
Yeah.
also one of the antibiotics that perhaps, I'm just assuming here because that's one of the indication. Maybe she does have osteomyelitis, and that's why the flucloxacillin was prescribed. It's an antibiotic medication, and of course, some people react to it. And if there's a reaction, of course, you have to stop, and then an alternative or a different medication, if required, can be used. So it's not directly a pain medication because it's an antibiotic.
Yeah.
Perhaps she may have been having pain that, having maybe investigated or done some X-rays or tests, it was found out to be osteomyelitis, and then flucloxacillin was one of the medication. But any medication that one does react to, of course, although there are different levels of reaction, and based on the level of reaction or the type of reaction, if it's one in which would always happen when you take the medication, then of course that has become a drug allergy, and that needs to be noted down in one's record. And if it's a type of medication that the compound in it is also found in some other medication, say there's some antibiotics that contain sulfur, like septrin, contains sulfur. If one reacts to that, it's very likely one will react to other sulfur-containing medication. There are some antibiotics, other antibiotics that contain sulfur, and some other medication that do that. So that's why part of what we do, when we take history or take information from patients, is to find out which drug they've used in the past that they react to, and if there's any medication we are thinking of prescribing that may either have a similar consequence that could potentially lead to a reaction, we either avoid it or we get to monitor closely if we really need to use it. So as if there is any sign of a reaction, that is be stopped immediately and appropriate intervention given.
Thank you. I'll just add here that it's funny how you can even take a medication. You may have been taking a medication that you didn't react to, and then you take one day and you react to it. Yeah. It actually happened to me. This was happening in 2019, early 2019, or 2018. I was in the ICU of one hospital in Lagos. I won't mention it, and they were treating me for acute chest syndrome, and I had so many things going in, and they gave me one particular, I think it was one of these, they give me, when they give me a lot of this pain medication, maybe it was hydrocortisone, I think. They had just given me, I think, in the morning of the day before, and then this doctor gave me, and before you knew it, all the machines were beeping my heart, and the other was like, what did you give her? What did you? She was like, but we gave her in the morning. And in fact, this doctor had to go and bring it out of she had to go and bring out the pack out of the bin and show them that, see, I didn't give anything different. It was so funny that I had that medication on that same ward so many times. I didn't react. And all of a sudden, I reacted terribly to it. So again, that's why all these things must be monitored. Kudi Sini says, what pain medication can a toddler take apart from aspirin when having a painful crisis? That's the first one. Tinuka continued by saying the itching, that's the lady with the daughter that had itching, says the itching continued for like 2 weeks before it stopped. She was given Oralox 20 milligram as a replacement. I want to know why the itching, and is Oralox as effective as flucloxacillin she ought to take? She has osteomyelitis. Okay, so Tunika has completed her question. The new one she was given, is it as effective? I didn't even know children could have osteomyelitis. I don't know. I thought it was maybe just adults. But yeah, so is Oralox as effective as flucloxacillin? Why did the daughter itch? And what other painkiller can a toddler take aside aspirin?
Okay, let me take the one of why the toddler eat, because as we mentioned, I'm sure the child may not have used the medication in the past before. And from what I just explained now, part of the constituent of the glucosylcerin might be what she reacted to. And that's why, that took a while to resolve. And then the doctor had to change to some other thing. Because glucosylcerin is one of the very effective antibiotics for osteomyelitis, because it actually penetrates the bone. It gets to the level. There are some antibiotics that are able to really do that. The antibiotic that was replaced with can actually also do that, but maybe
Okay.
not as effectively as the procalcitonin. But
Okay.
as it so appears, or it so happens that the child reacted to procalcitonin, the drug reaction can even be more severe, than the osteomyelitis itself, and that's why it's important to, do away with the flucloxacillin and go for the next best one. It might
Okay.
not be as effective as the flucloxacillin, but that may be the best, because if not for that, it's a child. There are some other antibiotics that could have been used, but that can affect the child's development because the child is still
Okay.
growing, particularly with
Okay.
the bones. There are some group of, like, called the quinolones, like the levofloxacin and the rest, could have been a good alternative. But because the child is still growing, if the doctor does prescribe that, it can affect the child's growth and development. And that's why I think the next best one is what the doctor has already put. It may now take a longer time to clear or to treat the osteomyelitis, but it's
Okay.
safer that way, because you cannot continue to give a drug like that the child reacts to, and then you cannot start a medication that will affect the child in the future. So I think
Okay.
that's the best way to go, about it. Now, regarding the other aspect of the question, in that what else you can give to a child aside from, I think you mentioned aspirin. If I heard,
Aspirin. Besides aspirin. Yeah.
okay, and what aspirin is one of the anti-inflammatory too, but it has the same effect as NSAIDs. So
Okay.
on the stomach, like you mentioned, in terms of causing ulceration or some abdominal pain and everything. So um, of course, the other medication too can be used, including even the paracetamol. And that's why I said combination of more than one medication. So if one wants to avoid, because the same effect like we talked about for NSAID that can happen to the kidneys, or even in the loss of blood from the stomach if it causes an ulcer, can also happen in children. So
Okay.
the same does apply to only use it for a limited number of time, and then to combine with paracetamol. We didn't even mention the cons with ordinary paracetamol too can have effect, particularly
Yeah.
if one takes in excess. We know that sickle cell disease also comes with some liver, issues, problem,
Yeah.
because of the workload the liver has to do with the breakdown products of the red cells. And of course, that's part of what leads to the gallstone developing. That's part of what leads to the yellowness of the eye,
Yeah.
and the lights for it. So even prolonged use of paracetamol, particularly in high doses, for a long
Mm.
period of time, can further affect the liver function. So that's also a
Yeah.
downside with the use of paracetamol itself. But to answer the question in terms of what the child can use, of course, the combination of paracetamol and this, and of course, the topical agents too even comes more in place with children, because they even
Okay.
have a smaller body surface area. So whatever you apply, they even get absorbed and more effective than adults because of the larger, area too. So combination of all of this, will definitely help with that. And for children, part of the thing now to prevent like this development of osteomyelitis now, aside from preventing malaria that even adults do get and children also get, children up to the age of 14 in some countries, up to 16 in some, also need to take some antibiotic preventive medication,
Yeah.
because that's the time in which the spleen stop working per se.
Mm.
And at that time, because the child has not been exposed, an adult would have been exposed to some infection while they are younger, and they would have developed some form of immunity, at least
Unity.
some level of immunity. But a child, would not have done that just yet.
Mm.
And that's why penicillin V is one of the antibiotics that are given to children even up to their adolescent age, to help their body to ward off infection, stop that from becoming overwhelming, because the immune system is not fully developed yet, and they
Yeah.
can succumb to severe infection if it does find its way into the body.
Okay. Thank you, Doctor. Someone simply 100% says AA from the US. Thank you for this great info. Yes, thank you, Doctor. And Waltham Fabric says Dalacin C 150 milligram is also good for managing osteomyelitis. Okay. She's the mother of a warrior, so I think she knows. Sholan says I had osteomyelitis at age 8. That was answering my question when I said I didn't know that children. What is osteomyelitis? Just briefly, Doctor. I know that that's not the topic, but I'm just curious.
Oh, okay. The osteomyelitis is the medical name for bone infection.
Oh, right. Okay.
Yeah,
Okay.
it's usually caused by some bacterial infection, in which
Okay.
can be some people with the chronic leg ulcer, for when the wound is infected, the infection can track all the way down to the bone. But some can even develop the osteomyelitis, the bone infection, by a bacterial organism that may be circulating in the blood and then may develop into an infection in the bone. So osteomyelitis just simply means bone infection.
Infection. All right. Thank you, doctor. So the lady says, Kudisini says, thank you. So thank you for that. I have just two more questions. Yeah,
No.
two. So the first question is, can toddlers use opioids? So I wasn't even, it's not even in my notes, but because of the question she asked, I'm just wondering, can toddlers use opioids? And if yes, at what age do they start? And that's the first one. The second one has two parts. The second one is that, is there anything called psychological pain that maybe the person is not physical, it's in the mind? That's number one. And number two is, where does pregabalin and gabapentin come in pain management? Because I've had one pain before that my friend said use gabapentin. That's the first time, and I think sometime last year or 2 years ago here, I had this pain, and they were going to place me on a PCA. But before that, the pain team, because we have a pain team, aside from the pathologist, the pain team came to see me and said they wanted to try pregabalin, of which I reacted to it, and then they stopped it. So those are the three things I do use: gabapentin, pregabalin, and morphine. But so psychological pain, and how does pregabalin come in pain management? I'm a bit curious. So those are the last two questions for me: opioids and toddlers, and the other one.
Okay, so for the opioid and those are very good questions. So for the opioid and toddler, the simple answer is yes. Well, when you're talking of toddlers, we're talking of maybe those they are about a year or 2 years or 3 years, for passive for it. So definitely they can, because if you look at it, children do undergo surgery and they undergo anesthesia.
Yes.
And some of the medications used as by anesthetics are actually opioids. Some are actually opioids or even so they can actually get to use it. However, of course, you would want to use some other level of pain medication before getting to that, if need be, for that. So they can actually use, but we don't, recommend it as the first line if you take it that way. We usually try to avoid using it for as much as possible, but of course, you cannot continue to see a child really wailing in a lot of pain. If there's a need to give opioids, the child can actually get opioid. Of course, there's a right dosing, and that's why opioids are not things you're going to give at home, to a child, whether in injection form or oral form, unless it can be formulated and be given that, okay, this is a prescription to give. Many times, if a child will need opioid, it's best given in the hospital, because children, as I used to say, they are not small adults. Children are children. They are not. So it doesn't mean that you as an adult to take a full tablet. They not say, let me break into four. No, children medication dosing is calculated based on the weight, and that's why in hospital to be given. Now, the second question about psychological pain, that is, remember I mentioned that pain is subjective. That, like they used to say, beauty is in the eyes of the beholder.
Yes.
Pain is no matter what the doctor says or any other person says, it's the person that is feeling the pain that can say. So, and then you cannot judge to say, oh no, you don't really have pain. Of course, a number of people have tried a number of things, maybe the placebo effect. The placebo effect does not even mean that the person is dependent on it. Because as I mentioned at the beginning, that there's a pain pathway. So there and that would lead to the third question you asked. There's a part of the brain. There are some chemicals in the brain called a neurotransmitter that are involved in this pathway, and that is one of the reasons why it's important to rapidly and effectively control pain for people with sickle cell disease, even from when they are small. And that's why many of people that live abroad, in the Western world and have adequate health care, and they get proper treatment early enough. Many of them have not had what I may term the psychological scar from being in pain for long period of time. For some, the people in this part of the world that may not have had that privilege or that opportunity to have that. Because over time, this pain syndrome, this painful episode, this crisis, it has a psychological effect on the individual, which, have an impact on future, episodes of pain. So without a shadow of a doubt, there is some psychological aspects to every type of pain, as it were. But at the same time, too, there's now a thin line between the psychological aspect of pain and dependency issue. Because the thing is, at what point do you tell that this person is, well, we don't, in the medical parlance, we don't use the word addicted to. We use the word dependent. At what time or what point in time can you say this person is dependent on this? At what point in time can you say this person is psychological? Or you can have a psychological dependence and you can have a physical dependence, on such medication. So it's one of the very gray areas of pain management. And as you mentioned, hematologists are not pain specialists. Though we know the pain medication that work best based on our experience in it. And that's why, it's also that there are not so many pain. Even in this part, in this part of the world, we do have pain specialists. And there are some cases in which, we do invite them to be a part of it because, there's a lot. Some people go for, specific courses or knowledge or training in pain management alone. So as an hematologist, it doesn't equate to the fact that the patient is a pain specialist. There are pain specialists. Many of them are even anesthetic because that's part of what they do. Anesthesia is to prevent people that are having surgery from having pain. That's why they put them to sleep and then they don't get to have pain when they wake up, or at least get to control it with pain medication. So there are pain specialists that may be required at some instance. So there's a thing like, but that can even be a whole topic itself, depending on psychology. I'm sure you talk about mental health and sickle cell disease. There's a whole lot. And pain management have an aspect of it. It's very difficult to tell at what point in time there's a psychological component to it. And that's why even psychotherapy also helps in terms of, having to teach people coping, techniques of coping mechanism. Because if one doesn't understand oneself and then to have the appropriate insight, and for those that may have crossed to the level of becoming dependent, or there are also, treatment methods or things that can be done to get them off. Because as an hematologist, I've seen a lot. You've seen people doing a whole lot of things. Pentazocine, people breaking the bottle, putting it in Coke, drinking. You people, of course, injecting themselves. A lot of things, so many that time I don't even allow to go into that. So a lot of things and it's a very thin line. Of course, the individuals do not want to continue to grow in pain, and over time, months and years may get tipped into the dependency. So there's a lot of psychological aspects. There's a huge psychological aspect of this, so that needs to also be looked at. But that's like a whole topic on to look at. So to your last question regarding the pregabalin, gabapentin, the what we call neuropathic pain or nerve pain, which some chronic pain syndromes can lead to. Some will say no matter what, the pain is almost always there. But you cannot be having pain crisis for 365 days in a year. Of course, having had the appropriate treatment anyway, it's not likely, that long as it were. So, but clearly, so this use of pregabalin and gabapentin, they are actually medications that work well for nerve pain. and they also work in
Okay.
the brain, but not like opioids. They are what we refer to as pain adjuncts. They are not directly pain medication, but they help with
Okay.
pain management. And as you did mention in your own instance that the pain specialist wanted to try that first before. So they are not standalone pain medication. They are like add-ons. They are adjunct
Okay.
pain medication, particularly for chronic pain, nerve
Okay.
pain, those way, because that the gabapentin, that GABA part of the name is the name of the chemical in the brain that modulates pain in the
Okay.
brain.
Okay. All right. So therefore, nerve pain, and it's just like another way of attacking the pain. Okay. Cynthia
Yes.
says, me, I am psychologically tired of pain. But my question is, can one actually get used to pain? I think that'll be the last question for today. Can one actually get used to pain?
Well, yeah, I said the psychological aspect is a whole big aspect of that. So, I there's no yes or no answer to this per se, because
Okay.
you can't really say, saying that, the pain has been going for so long that, the person might have found some psychological coping mechanism to be able to live with the pain. But it doesn't mean that the pain cannot be addressed with the adequate, treatment for it.
Mm,
Of course, we first need to identify the cause of the pain clearly. At times, it's difficult to do that. Some will just have what we call a chronic pain syndrome that is always there. And that's where drugs like gabapentin, and pregabalin can come in, or some other ones like amitriptyline and the likes for it. Some people might even have depression. That I said, the mental health or psychological aspect is a very, larger. We say maybe that was what they had. It was even some minor depressive episodes that giving antidepressants to help resolve that help them with their pain.
mm.
So it's a very wide area really to look at the psychology of pain or the psychology when it comes to sickle cell disease in general.
Okay, all right. Thank you so much, Cynthia. Dr. Adelabu has said there's no yes, it's not a yes or a no answer. It depends on the individual. Everything is individual based, or you understand what I'm trying to say. So on that note, I'm going to say I planned for this to be 1 hour, but we've used 1 hour and 35 minutes. So I
Yeah.
think we've done total justice to this. Let me thank you very much, Dr. Adelabu. For those that are in Lagos, Nigeria, Dr. Adelabu is based in Lagos. If you do need to say hematologist, you can reach out to him. Again, please follow his Instagram page. I tagged it in the post with the flyer, and he has his foundation. I think they're into blood cancer awareness. So please follow both of his pages. And if you need to see a hematologist, you can always reach him. Thank you so much, Dr. Adelabu, for taking time out of your Sunday evening to come and spend with us. We really do appreciate it. Thank you for educating us. And I hope that when next we'll be inviting you to come to talk about another topic, we hope that you will be able to honor our invitation. But we thank you so much for today. I've learned so much. I have jotted and jotted and jotted. Thank you so much for doing justice to this topic. Just a note, please, of warning, especially those that can get medication over the counter. Don't go and start calling this name to the pharmacist and saying you want to buy this, you want to buy that. Remember that you don't know how you react to this thing, and these things need to be monitored. Adichie says, thank you, Doc, and Sickle Cell Club was a very insightful session. Thank you, sis. Very soon I'll be inviting you to come. She's a doctor. She's my doctor friend. And Simply 100% says thank you. If you join this session halfway, I would advise for you to watch it from the beginning, because we went straight into it from the beginning. So take your time. Cynthia says, thank you, doctor. Thank you, Mrs. O. You're welcome. Until we see you again next time, maybe in 2 weeks' time, I hope it will be Warrior Series. Thank you so much. And I hope you guys take care. If you've not had your COVID vaccine, but doctor, what are you going? Somebody was asking. So somebody was asking about the COVID vaccine when you were speaking and saying, has anybody had the COVID vaccine, and that she's a bit scared because it's not FDA approved. She doesn't know if there will be side effects later. So what would you say to the people watching and not yet sure about the COVID vaccine? I have had mine. I've had mine, and I've even taken my daughter, my teenager, to have her first dose. She's going to have two. because she stays with the vulnerable adults, but generally in the schools, they're giving them just one. So what would you say to those that are still not sure about the COVID vaccine? Walton Fabric says, thank you so much, sir, for your time and resources. God bless you. Amen. So what would you say, doctor?
What I would say is actually everybody is actually advised to get the COVID vaccine. For sickle cell group and even some other categories, really, if I put it that way, I even, it's even more important for them to actually have it. So really, of course, while, on it, you're going to be monitored, and followed up if you do develop any reaction. But please, it's advisable that you should go ahead and have the vaccine as soon as possible.
Okay, Dr. Adelabu has said it. Inform your hematologist, have the vaccine as soon as possible. August Nika says, thank you, doctor. Thank you, Mrs. O. You are welcome. Thank you, everybody, for spending your Sunday evening with us. Thank you so much, doctor. And on this note, we'll call it a day. Everybody have a blessed week. Remember, Latifat Fajolu says, thank you, doctor, and thank you, Mrs. O. You're welcome. Thank you for thanking us. We hope that we'll bring another topic to you soon. Please follow Dr. Adelabu on his social media. And again, if you need a hematologist, this is another hematologist that I strongly recommend. We don't have enough hematologists in Nigeria in general, and even in Lagos. So I always tell people it is important that you see one. Some people say there's no hematologist in the hospital I am in. You can let them bring one in, and it's like a consultancy. You pay just by basis of them coming to see you. It is very important. You cannot separate hematologist from the care of a sickle cell warrior. So thank you so much. Everybody have a blessed week. Thank you, doctor. I really appreciate it. God bless you, sir. Thank you.
Thank you so very much for having me. It's been
all right then. Thank you. Bye bye, guys. Take care. Bye.